A little bit about my childhood. My dad was a pharmacist when I was a kid, and I kind of felt like he was in the sciences. I wanted to do something in the sciences, and I became a dentist. And I've been practicing for 35 years. I went to UCLA. I went to UOP for dental school. I did a residency for a year in a foreign country, and then I started working in private practice. And I had a mouthful of metal as a kid and a lot of amalgam fillings. And I said to the doctor one day, I would love to get one of those white fillings in my mouth instead of the mercury fillings. And they said, they're too big. You need a crown on that. And I'm like, why do I need a crown? Well, it's too big. It won't support it. So once porcelain restorations came out and we learned how to bond to dentin in the 90s, I was like one of the first in line to learn how to do it. And then I got into porcelain veneers. They bonded in the same way as the porcelain inlays and onlays. And I just kept taking courses on non-metal dentistry. And then I realized how strong they are, even though they were new and they were kind of innovative at the time. I thought, hey, I can probably restore a whole bite with these and put the porcelain on the biting table everywhere. And then I started looking for ways to restore a nice bite. And I was noticing a lot of my patients were saying that they don't have their headaches anymore, or they used to have neck tension and it's gone now, or they used to suffer from TMJ and I'm not getting the click anymore. And I realized that the bite had a lot to do with the TMJ, and they are connected on the same bone. So the lower jaw and the TMJ is on the same bone. And so I can see how there's a connection between that. And so, so that's sort of how I got to where I am. So I started learning a lot about TMJ, and that's been a deep rabbit hole, and I've been in that for the remainder of my career, helping patients with TMJ. And the way we help patients with TMJ is we kind of break the treatment into two phases. We say a phase one and a phase two. So a phase one is, let me help you with the symptoms that you're experiencing, the headaches, the neck pain, the jaw pain, whatever the facial pain is that is bothering them. Let's get you out of pain. Let's figure out how to do it. Phase one is completely reversible. It's sort of like a test. It's like putting your foot in the water before you actually do any real treatment. So we just, we do whatever we can to get the patients out of pain. And I'm going to go through some of that in the lecture. So we're going to start by talking about really what is TMJ? What's the definition of someone with TMD or TMJ? And the definition that I've adopted, that I use the most, is I call it an imbalance between the jaw joint, the muscles of the jaw, and the bite. So there's a zone of balance or harmony, we call it a zone of comfort, that when you get a patient where the muscles are calm, the joint isn't being compressed and the disc is sitting over the joint nicely, and the bite is sort of level to the horizon, you're in this sweet spot, so to speak, and that's this harmony position. And it's a structural functional position. So when we're talking about diagnosis, I'm going to look in the diagnosis for things that would say, you're not in harmony. This is not in balance. And this is how I'm coming up with my definition of what TMJ is. And then I treat from a structural functional point of view. There is, let me see, I wanted to share this one video because so many times we'll have a patient in our office and you'll work on one crown and the patient comes back and says, I'm having pain all the way up my neck, my head. I've got headaches. Since you've done that crown, I can't, and you try and adjust it. And I call that the straw that broke the camel's back syndrome. It's sort of like that equilibrium got broken by that one crown. That one crown was holding everything together for the body. And as soon as it lost its support, the body goes into a breakdown, a neuromuscular breakdown. And these are some of the problems that happen. I just put a video of a patient.
After I got my teeth done, I noticed significant amount of pain. It was so debilitating. I couldn't leave the house. I walked about with my hand on my jaw, and every morning, all down here, it would hurt. It still does, actually. I'm still going through that.
And it's just sad, but that's, let me see how to get the next slide here. Let me get some sort of delay on this. I'll just go. So there's another definition for TMJ. The other definition is called psychosocial bio. And believe it or not, all the universities this is what they teach. When you're in dental school, this is what you're going to learn is the psychosocial bio. And it's sort of like if you have a lot of stress in your life, the stress is what's causing your TMJ pain. And they look at your emotional well-being. They refer to psychologists and they ask about nutrition, your sleep habits, and what medication are you taking that is disrupt, and that's causing the TMJ. And I don't discount that stress can't exacerbate TMJ pain, but I'm coming from a point where if the condyle of the joint is too far back and the disc is slipped forward and you have a slip disc, I don't understand how reducing stress is going to put my disc back over my joint and give me room for my jaw to open and close freely. So this is why I became a TMJ doctor of structural functional camp. We refer to myofunctional therapists, chiropractors, physical therapists, osteopaths, and ENT doctors, where they're referring to psychologists, psychiatrists, nutritionists, drug rehab, and sleep. And that's more the conventional way to treat, using medications. I don't like using medications. I'm trying to cure, I know it's a bad word sometimes to say, we're going to cure your TMJ, but I don't see why we can't say that, because that's really what we're trying to do, is we're trying to solve the problem. Well, the dental board says we're allowed to do Botox now, and to solve patient. Botox is a patch. It's like taking two tablets of medication. You're going to give Botox. I feel much better. 3 months later, they're still in pain. You didn't do anything to find this harmony structural. You didn't move anything around. They're still in the same pathologic position. And that's why I don't really use Botox in my office. I try to solve the problem doing this structural functional technique. And I'm going to show you how we do it. So diagnosis is very important. And in your packets, what I did is I gave everyone what I call the platinum form. Now, treating TMJ is not like you fill out a medical history and then someone comes in and tells you they have, I have headaches and neck pain, and that's how you're going to diagnose this. This is called the platinum form because the amount of questions you need to ask a patient to diagnose TMJ is insane. And so I try to get them to fill these out before they come in or what. But if someone's having headaches, how often are the headaches? Where are the headaches? On a scale from 1 to 10, what, are they a 5 or a 6? When do they come? In the morning and the night? And how long do they last? So there's a million questions. So many of these patients who come in to get help from TMJ have seen so many doctors. They've been to neurologists, they've been all over. You got to ask their history. And it's like, it'll take you an hour and a half if you got to ask all these questions. It's just so much better to have this form and have them fill it out. Someone has TMJ. This is the platinum form. I have all the symptoms on this page, and it says of the frequency, the intensity, and we have the patients number them, like which is the worst of those, what do you say is number 2, what's number 3 of the symptoms. So taking a good diagnosis is key to taking a good history on your patient is key to diagnosing TMJ. So this one's amazing, like jaw locking, jaw popping, jaw clicking, left, right, both, yes, no, all these issues. There's no way you're asking the patient all these questions. So I put them all together in a form. You can put these on your own letterhead. You can use them in your office. There's nothing in here that would prevent you from saying, I didn't ask that you didn't ask that question. It's in here. Sleep, believe it or not, is about 50% of TMJ patients have a sleep component to it. So meaning that if you're trying to help someone with TMJ, but you're not helping them with their sleep, you're not going to help them because you got to control your patient on a 24-hour basis in order to help someone cure themselves from TMJ. That's really what the bottom line is. So if you, and just think of it again with the slip disc. I have a slip disc. I'm going to make a new bite plane for you that is in harmony with the muscles in the joint, but I can't wear it when I eat. I have to take it out to eat. How are you going to help somebody? That's like if I had a bad knee and the doctor gave me a splint on my knee. Hey doc, I can't run. I can't run with this splint. I have to take it off to run. Like, are you going to heal your knee? No. It's the same thing with the joint and eating is like running on your knee. And so that's why it has to be, you have to control your patient on a 24-hour period. So when we make splints for somebody, we make sure they can eat with them. We tell them not to take it out. We usually sometimes have a night appliance that they eat with, and then when they sleep, they put in a sleep appliance to sleep with. But we don't want them to go back to their normal habitual bite that's in a pathologic position because all these muscles have memory. And once they remember that you fire the same synapses of that pathologic bite, and we're trying to deprogram these muscles, we're trying to get them to forget and trying to get all these muscles to relax. TMJ is really, even though we talk about a balance, there's 4 main muscles that attach from the skull to the lower jaw. We call them the muscles of mastication. And this big one here causes everyone a headache called temporalis anterior. This is the masseter. It's right here in your cheek. It's for mashing. The temporalis anterior is very posturing muscle. Then there's 2 more that attach. They're on the inside. They're called the pterygoids. And there's a medial and a lateral pterygoid. And we got to relax all those muscles in order to solve this TMJ. So we're always looking at the muscles and the muscle memory, and we're trying to deprogram them. And the teeth and the bite and the joint, to me, they're like obstacles more. The muscles sort of control everything. Like water going down a stream downhill, the water's going to make it downstream, but all the rocks and all the stuff in the river going to divert the water this way or that way. And that's what the jaw joint and the teeth are like, obstacles. And the muscles are trying to find their relaxation. And that's what we're going to try and do to allow the muscles to relax. So, this is a picture of hunters and gatherers. One of the things they talk about is that the reason why there's so many TMJ patients today versus, say, in 1970 or maybe even hundreds of years before, they say hunter and gatherers never had TMJ. Who knows? But they had nice, big, broad arches, and they had big airways. And the reason why they think there's so much corruption today is our food is too soft. So we don't eat the food that the hunter and gatherers ate. They ate these really strong food. They say you couldn't even eat their food today. Our jaws aren't built for it. But if you're working your jaws out with a hunter and gatherer's diet, when you go through puberty, these jaws are growing to their maximum DNA potential. And what they're saying is that because the food's so soft, this maxilla bone is sort of stunting in growth, and it's not growing to its full DNA potential, so it's smaller. With a smaller maxilla, the lower jaw always likes to find its friends under the maxilla bone. It likes to nestle itself under there. It doesn't care if the muscles aren't happy or the joint's not happy. The teeth like to find each other. They find their friends underneath the maxilla bone. So if you have a stunted maxilla bone or a bone that didn't grow to its full DNA potential, then you have a jaw that is now nestling itself under this small bone. And that's why when you look on a CT and you see a lot of jaws that they're bent, like the condyles are bent back like this, because they should be straight, but they knocked into the maxilla bone and they couldn't grow to their full thing, so the bones kind of go like this because they weren't able to grow out the way they're supposed to. So I've been taking tons of lectures for my 35 years, and the lectures that I've been in state that it's really an environmental issue, that TMJ is environmental issue. Like, we're born with a perfect DNA, and as we grow up, it's getting corrupted in the environment, and this is why, because of the food that's too soft. It's also the type of foods we eat isn't the same. We're not getting the same nutrients as hunter and gatherers got. They ate a lot of organ meat and different things, but that's why. But this is one of the reasons for why so many people have TMJ, and a lot of it gets made worse by orthodontists, or they go in and they make it even worse. They narrow the airways even more. But if you look in someone's mouth, these are just some clinical signs that if you saw someone with very narrow arch or a V'd arch, it's called a V'd arch, it should be a nice broad arch. And if you saw how this patient bites, the lower teeth are going to nestle right underneath this low arch like that. And this is called a reverse curve of Spee. So, or when you look at the, oops, let me go back for a second. When you look at the anterior 6 teeth here, and all of a sudden it drops down, we call it bicuspid drop off. But this is a reverse curve of Spee under here. This should be level, the bite should be level to the horizon, and this is a hypoocclusion. This is dropping down. So the patient's really, like, if they went into their habitual bite, they're going to see a deep bite or an overbite. Usually you're going to see a lot of anterior wear facets in the anterior. So you see how they are broken? If you notice, this patient has restorations already, but these, the lower jaw is in a sling of muscles. It kind of wants to be free all the time. It wants to be in its healthy position. And here it is under the cage of the maxilla, and it's always trying to get out. And so even when it's chewing and eating, you're going to be chipping teeth here, and these teeth are always worn down when you look at people like that. It's another sign. A deep bite. Obviously, that lower jaw is way back here, like this, and the patient is not in a place of harmony with the muscles in the jaw joint. But these are just looking at the teeth. There's another picture of the worn surfaces, more reverse curve of SPE. And I'll show you how I fix all this. But a flat occlusion, another sign that someone may have TMJ is if you look at the curve of Wilson, when these teeth are going in like a vise on the maxilla, they're going in this way. Natural curve of Wilson is going to go out this way. So it's sort of a reverse curve of Wilson. And here you go. The lower teeth are trying to get underneath, find their friends. You can see all the recession that's occurring down here on the patient as their forces are not aligned properly. So these are more signs that this patient may have TMJ. Besides clinically looking in someone's mouth and noticing all these signs, I like to look at a CBCT and see what you can see on a CBCT. So how many people here have a CAT scan in their office? You do? Yep. So most of us, if it's a large field, you can see a lot of it. I'm going to show this one video, and let me see if I can. Is it playing? Oh.
And all the different things you can see when you look at a full head CT scan. And so there's 3 different views that you can see on the CT scan. It's a 3D image. So this is called coronal, axial, coronal, and sagittal. And one of the things we look at is if I take the crosshairs and move it over, take the crosshairs, just move it over to the right joint. And then I double click over here, I can see the ear, and this is the jaw joint. One of the things I'm noticing right away is that you can see how the cortical bone there goes away right here. The joint's a little bent on the right side here. And most likely that this joint is being eroded when it opens and closes. Also, if you look at the coronoid process, look how high it is. It's above the condyle, the height of the condyle. What that tells me is that the temporalis anterior muscle that attaches right to the coronoid process
This muscle.
pulling really hard. And so she's got really tight muscles. There's a good chance this patient has been suffering from headaches her whole life. If I continue along, I can then see.
Yeah, so just to stop you, but this anterior temporalis muscle attaches onto the coronoid process. That bone's really big. It's called elongation in medicine, and it's creating so much tension that it's causing the bone to elongate.
The maxillary sinus and all the sinuses here. Look how clean and clear they are. I can see if there's any problems with the sinus. I'm also now looking at the teeth, and I'm looking for abscesses or anything weird that may be on the teeth. I can also see how big and large the airway is. And this is a nice big airway. If I want to measure it, I can. I just come to this button called airway, and I can measure the volume inside the airway by just clicking these buttons and hitting apply. And you can see, well, it's only 112. And I think the reason why it's wide, but it's not so great, is this uvula right here looks a little hypertrophy, and it's just sort of laying right in the airway, blocking a lot of the air passage. And going back and just looking
that
at
could
the tongue
be
right here.
that could be a sign of a mouth breather. So you want nasal breathing. We do lip taping. Has everyone heard of lip taping? You lip tape, nasal breathe through the night, but if they're mouth breathing, this uvula is just laying all the way into the airway, and can be causing the problem. But
See how the tongue is nice and up at the palate? That's where you want to see it. If you see the tongue falling down, we call that low tongue posture. And basically, the patient may need myofunctional therapy to
Not this
get
patient.
healthy. And if you look at this joint, we're coming up on the left joint again, and you can see that the coronary process is not nearly as high as it is on the right. There is a little bit of cortical bone around the condyle, and so it's not as damaged on the left side than it is on the right. This is the ear over here. So look at all the things. You can also see how compressed that joint is. So in the glenoid fossa, it sure doesn't have enough space. When you look from the coronal view, you can see how tight the condyles are inside.
There should be 2 or 3 millimeters space between the joint and the.
One is 2 or 3 millimeters of space there. You can also look at the entire skull with this volumetric view, and you can see here this is called synovial notching. And the notching is a sign of clenching. The bone grows a little more when there's heavy forces on the body. I can also see the neck, and you can see how C1 is not level. It's very compressed between the head and C1 and C2, very compressed. And I can, if I want, I can just kind of cut away
It's sort of a
this part and
military
look
neck.
at the neck from the back. You can see how her head is just leaning towards the right, and that her head is just not on perfectly straight. I can change it to bone, make it look like bone, and I can kind of turn it around and just see how the posture and her bite is affecting this patient.
This is very
And
compressed.
so
In
obviously I
the
can see a panel. If I want to look at all the teeth, I can cut a panel. She definitely has.
what is that? All right, let me get out of that. But she had an abscess there on one of those teeth. Looks like on a root canal, and you can with the CT, I can see the joint, the sinuses, the tongue posture, the airway, the neck. So a lot of time there's a lot of literature that relates that your posture is related, your bite and posture have a relationship. So if the C1 is going down like this, the bite's probably not level. Your bite plane, if you just come straight out, you're going to hit C1 or in between C1 and C2. It should be like 20 millimeters between the head and C2, about 8.5 millimeters in between each one. When you see them all compressed like that, the bite may be compromised, and also lifting the bite's going to affect the posture. This is a diagram of a good joint, which a dentist named Gelb designed. It's called the Gelb 4-7 position. And what he did was he basically compartmentalized the glenoid fossa. So this is the fossa, that's your ear, this is the condyle. So you draw a straight line down the glenoid fossa and then write a straight line at the eminence. And he made all these departments. When you put your hand here, you don't want any joint really in 2 and 5 position. You don't really want any joint in 1 and 2 position. So you can see if they're superiorly compressed or they're posteriorly displaced condyle too far back if it's in the 2-5 position. Here's another, this is the same, looks like the same shot of the same condyle before. This is just someone I was just looking at. And you could just see there's a lot more space in between this condyle than there is superiorly in the fossa. And then this one is very compressed. It's all in the superior compartment of the glenoid fossa. And you can see how far back it is on the left joint here. That's the ear, that's the joint, and it's all the way back. That means the disc is most likely forward. So I'm diagnosing TMJ, and I'm figuring out what the problem is. Is it in the neck? Is it in the tongue? Is it in the breathing? Is it, are the sinuses clear? What's going on with this patient? Is the bite off? All the stuff that, this is some weird stuff you sometimes see. Someone who's got, it's a bridge of bone that goes across C1. like that. It's like a lot of times when that other neck was very straight, it's called military neck. And it's like, it just doesn't have its natural lordosis in the neck. And so there's a lot of tension in this neck. And so a lot of it's coming from the muscles. It could be a forward head posture or something, but this bone is building up. There's actually an artery that runs through there called the vertebral artery. That it could be dangerous for people. You know, I don't know if they want to go to a chiropractor with something like that, but and they're again showing the 20 millimeters. That's more normal. This is what we're looking for, and this is what we see a lot. Somebody with a compressed neck.